Rossler speaking, and I work for the Academy. And I'm just going to pause for just another moment and make sure that anybody who wants to join has joined, and then we'll get started. A whole host of people on the phone that have joined us or on our link, our Zoom link here. So we're so grateful that you could all take a few minutes to join in this call with us today. And we're pleased to welcome you to this first interactive webinar for the Academy of Communication in Healthcare. And we're even more pleased that you're going to get the opportunity to hear Dr. Peter Lickstein talk about his use of the challenging cases versus the integrated exercise at Wake Forest, and how to make the most of the end of your workshop in doing so. Throughout this interactive webinar, we ask you to please mute your line while not speaking, though we encourage you to unmute yourself and ask questions of Dr. Lickstein or of each other. And if you're less inclined to speak, we certainly encourage you to use the chat feature, which is located at the bottom of your screen. And I'll be moderating out to see what questions you might have that we might be able to pose to Peter or to the rest of your colleagues on the line. With that in mind, I'm going to proceed with an introduction of Dr. Lickstein, and also myself and my colleague. Rachel Porch, Program Manager for ACH, is also on the line and supporting the call, and you'll be hearing from her at the end. And as I mentioned, my name is Greta Rossler, and I work with ACH to lead programs across the country as we work at different organizations. With that being said, I'd like to introduce you to Dr. Peter Lickstein, who is a general internist actively engaged in ambulatory and inpatient care and teaching at Wake Forest School of Medicine in Winston-Salem, North Carolina. He completed facilitator training with the Academy of Communication Healthcare and served as co-director of the facilitator training program. Peter currently leads the doctor-patient relationship and communication skills curriculum for medical students and residents. He is medical director of the General Medicine Innovation Service at Wake Forest Baptist Medical Center, where he also leads the Train the Trainer program to enhance relationship-centered communication, also known as PERC. He is PI for an initiative to move hospital rounds from hallway and conference rooms to the bedside with emphasis on patient and family-centered communication, funded by the Josiah Macy Jr. Foundation and the Institute on Medicine as a Profession. Peter is governor of the North Carolina chapter of the American College of Physicians, and he lives in Winston-Salem with his wife, Sissy Gamble, also a general internist. They have two grown children, Paul and Jesse. Welcome, Peter.
Thank you. Great introduction, and I appreciate the invitation and the opportunity to talk with all of you about kind of the gradually evolving or tailored workshop that we have here at Wake Forest. I suspect, like many of you, this opportunity to practice and teach communication skills is one of the most rewarding, gratifying, enriching aspects of my professional work. And so it's really fun to share it with you. So just a bit of orientation here. We're at Wake Forest Baptist Health, and I've got a map here of North Carolina, and you can see Winston-Salem up there right next to the mountains. And we have a beautiful medical center, and we're part of Wake Forest University. And in the background of that photo, you can see Pilot Mountain. But we're very near the Blue Ridge. It is a beautiful place to live. As Greta mentioned, we called our program to Enhance Relationship-Centered Communication, or PERC. And I wasn't very satisfied at all with that name until after our first go live. One of our colleagues called up and said, you know, those concepts are kind of percolating with me, and I've been putting them into practice. So that kind of opened up my heart to this little coffee pot. And that's a symbol for the Moravian community in Winston-Salem, part of our history. So we kind of like that. We have 8 trainers. We started in 2015. All 8 trainers are physicians, and but we've also been working with the medical school curriculum, the PA curriculum, residency programs across the institution. And the basic message is that PERC is working here and having an impact on clinician and patient experience. And one of our visions is that this will extend across our whole health organization, and that PERC will be spoken here by many people. So what we're going to do moving forward is talk about some of the ways we've been tailoring the workshop that we were taught by Calvin back in 2015, 2016 to make it our own, to respond to the folks we work with here and what we've learned from their experience and their feedback and observations. So in terms of a roadmap for our talk, by the way, this is NASCAR country, so that's why we've got the race cars here. I'm going to talk a little bit about the background of the integrated exercise, which I think all of us have learned as a fundamental part of the one-day course. And then an experiment that we've done that really has taken hold here, which is the challenging case exercise. And I'm going to spend most of the time talking about it and certainly be open to questions, concerns, input along the way. And Greta is going to be fielding questions and I'll do my best to respond to them. I did want to mention a caveat that the fact that we're searching for alternatives to the integrated exercise doesn't mean that this classic that we all learned and is part of our roots, our tradition is, to be thrown out. We're not trying to denigrate or diminish its value. We're simply looking at some alternatives that have worked for us, and we'll see how they sound to you. So I'm going to start just with a brief review of the classic exercise, the integrated exercise, which for us was always a capstone to the one-day course. You put together all three skills, 1, 2, and 3. You're able to demonstrate the potential of this approach to positively impact even difficult interactions. And also it's a final opportunity to practice communication skills with cases that are of greater difficulty than usually earlier in the day, greater than or equal to 5/10, using that kind of scale. And when we conduct the session, I'll go through this quite quickly because I'm kind of assuming that all of you have already been introduced or tried this. You bring the large group together. Maybe you had 2 small groups in the morning, but you bring them together in the afternoon. You request challenging cases, you elicit the themes, you honor the work as sacred and important. You choose a case, and usually our trainers here, this might have been an error, we kind of would step out and do our best to pick the best case. It was a little mysterious, I think. And then we come back and the nominator would usually go, oh no, they chose my case, but then would have surprise and relief when we said, we're going to invite you to take the patient's seat rather than the clinician's seat. Then have serial rolling role plays, get as many participants as possible into the clinician's seat. Begin at the beginning with skill set 1 and work through till the end, maybe add some other skills. Feedback along the way to the clinician and final debrief with the patient, and that was the nominator and the group. Let me just check. Does that sound familiar, kind of on track with the integrated exercise as you understand it?
Yeah, I have one question. Do you use one challenging case for all your clinicians, or do you then pick 2 or 3 challenges?
Yeah, and that's a great point, which I'm going to address, because previously when we used, I'll say, the classic integrated exercise, we had 1 case. And we found that sometimes problematic to keep everybody engaged. So I'm going to address that in just a minute. All right, I'm going to move along and I'll keep that comment in mind. So at Wake Forest, we were beginning to notice that it was, our trainer said this is consistently the most daunting facilitation challenge of the course. And at our frequent meetings and retreats, we were always kind of worrying over how best to facilitate the exercise. And it seemed like it was the most complex and challenging part of the day, and it occurred just when energy was at its lowest ebb. We also found that if you had two groups in the morning that had formed and were working well, that bringing them together in the afternoon was somewhat awkward in terms of group formation and performing. It seems like we stumbled some on trying to introduce the exercise and get everybody organized and oriented and set up. And the goals seemed like they were being driven by us as trainers rather than being derived as much from the group. So some of this may be, our faltering skills. And in selecting the case, just as you mentioned, have we chosen wisely? It seems like many folks would choose their greatest nightmare, not 5 to 10, but a 12 over 10 or whatever. And that frequently the cases seem to be overly complicated with medical, social, and mental health issues. I remember one where, it turned out the patient was malingering, and, no wonder our communication skills were not being very effective. Overrepresentation of chronic pain, narcotic abuse, and other types of challenges. And it was, since we were only using one case, it really was difficult to find one that would keep everybody interested. And I mentioned David versus Goliath, that sometimes it seemed like it was trying to prove that the David of communication skills could in some way win the day over the Goliath of terribly challenging and difficult patient interactions. So it was challenging to keep everybody involved. Sometimes we'd end with frustration, and we'd end up saying, well, communication skills can't solve every problem. I mean, that's an important caveat, but it's not a good way to end, I would say. So we had a retreat with our trainers, and we brainstormed and put together our experience. And what I'm going to be describing to you is kind of what has come out of that. And we've been doing the challenging case exercise for about 1.5 years now. And we're so firmly on board with it that I think we're not going back. So rationale and goals, we wanted to end the day on a high note with a win. We wanted to be a little less daunting. We liked real life scenarios from daily practice. And as one of our pediatricians said, this isn't PALS mega code. And it's not your worst nightmare. We're just working on communication skills here, things that will help you in your daily practice. We wanted to be sure to keep the focus on communication challenges, stay in tune with learner-centered goals, be sure that the scenarios were addressing learner goals, and as many people as possible in the group would be participating in developing those goals, and make the best use of our precious time and the resources of the group. So I'm going to run through kind of how we do it. How does that sound? Folks ready for that? Okay. So we kind of start with getting a list of scenarios. So I want to say this is getting a list, sound familiar, of scenarios rather than specific cases. So the question is, what communication challenges do you frequently encounter in your practice? Explicit emphasis on communication. And we really say, listen, there's a variety of things that you encounter that are not in the communication realm. So let's focus and use our time wisely for this. A challenge that you would love to get a consult from this group and from these trainers and facilitators to give you some options that you can take back to your practice. We're going to ask everyone to think of at least one challenge, and we'll work together as a group on these. So key point, starting with scenarios rather than cases. So here's an example. This is me as the trainer, got a group out there. Our neurosurgeons decided to that they would get 100% attendance. I only had 3 neurosurgeons, but it included the chair. Said, so neurosurgeons, what is a common communication challenge you encounter in your practice? And frankly, I was delighted by the response. They all three agreed. It's the patient with chronic back pain referred to my practice, so it's in clinic. The patient's expecting a surgical fix for their back pain, and I have to tell that patient that surgery will not be a benefit and it's not an option. So that sounded like a great communication challenge. So next, like the, I guess the classic integrated exercise, we elicit themes, honor the work. And then for each scenario, we ask the group to suggest which RCC skills might be helpful in addressing that particular challenge, that particular communication challenge. So I'm going to show you, this is not a very good visual, but this is just a snapshot on my phone from a recent workshop. So this is the pad that we were writing on. So, okay, so there were scenarios. Fibromyalgia, everything hurts. URI, requesting antibiotics. Vaginal bleeding in a pregnant patient who's really anxious about it. Expectations of a family regarding an elderly patient. Abdominal pain with a negative workup that was suggested by a surgeon, so very similar to the neurosurgery case or situation where the patient is being sent to a surgeon with unexplained abdominal pain. We then get the themes, as you can see: uncertainty, no quick fix, expectations, emotions running high for everybody. And then we didn't belabor this, but we got some suggestions of RCC skills that might be useful with each case. So list, teach back, there's some pearls here, legitimization and empathy, and that sort of thing. So we've got the scenarios. So then we have to move forward. So we give the expectation that we're going to do more than one. So we'll do several, and we'll also mention that we're going to have to manage time effectively, and we'll be moving things along. We enlist the group in setting the agenda, like choosing which scenario goes first rather than this mysterious trainers leaving the room and looking at the list and worrying over it and what's going to be the best case. We then ask the nominator to, let's say we got the first case, we ask the nominator to then develop a specific case. And it may be a particular patient they have in mind, or it could be kind of a combination of features from several patients. That seems to work fine. Clarify the nominator's learning goals. We negotiate if it would be best for them to be in the clinician or patient seat rather than us necessarily pushing them. So I recently had a surgeon with the patient with unexplained abdominal pain, and he just didn't get it. So being the patient was perfect. And at the end of that, he said, "Wow, it's embarrassing to tell you all what I've been saying to patients." And he really had some aha moments. We then dial in the degree of difficulty to match learning goals. So it doesn't necessarily have to be a 10. It could be something fairly easy, but something that the learner who has taken their day to spend with us, wants to work on. So we run it pretty similarly to the classic. We rolling or serial role plays. We coach at elbow and we get group feedback, although it tends to be, I would say, less laborious maybe. The group is already used to observers and giving nice observations and I noticed and that sort of thing. So it just seems like we're able to be a little more flexible in terms of how we're going to do the feedback to be most helpful to the learners. And then we do a debrief, and then we move on to the next scenario. And here's a few from recent groups. Like we have small talk before big talk. Well, not infrequently, clinicians tell us, "Hey, I'm not good with small talk. So what am I going to do? How can I make this my own?" And they get to practice some various ways of doing small talk. Or we're trying not to interrupt folks, but sometimes you need to. And how can I do that without seeming rude or impatient? We are in the South, don't want to be rude and that sort of thing. It's really interesting to see how many folks are concerned about this. I don't want to be rude and interrupt, but I get home late, and that's not good for my family. I'd like to get better at responding to difficult requests, or I want help in how to end well. That seems to be an interesting take of the per course is, oh yeah, let's focus a little bit more energy on ending as well as on beginning well. So from the standpoint of our trainers, they say this is no longer a huge facilitation challenge. In fact, we're using the same core facilitation skills that we use in other segments of the workshop, but maybe with a little more flexibility, because it's not as perfectly patterned, because rather than starting with skill set 1, then 2, then 3, you might decide to just jump in on ending a interaction like I mentioned was a learning goal for one of our participants. Now, some of the trainers, which would include me primarily, feel comfortable or confident doing some very brief or rapid fire role plays, kind of just deciding whether the facilitator will take the clinician role maybe and put the patient, or maybe be the patient. And we can run through sometimes literally a series of 4 or 5 goal-directed interactions to try things out without being so laborious or plotting. And that is an area, I think, for some additional facilitator training here. And then also, and perhaps you all are doing this, that since it can be awkward to meld or merge 2 functioning small groups into one, if those groups have maybe 4 or more, just make this the final exercise, but it doesn't have to be a larger group. Stick with your small groups. And when we've done that, it seems we're missing out on something in terms of getting a chance to see the other folks, and the other folks don't get a chance to see both facilitators. It seems to work maybe better. So some of the advantages that we've been sensing is that it's explicitly focused on communication challenges, and we don't get as detoured or waylaid as frequently as in the past by really complicated social, medical, and psychiatric problems. We really encourage this direct linkage between RCC skills and specific scenarios. We asked the group to work on that, and I showed you an example on the flip chart of what they came up with. The scenarios really come out of learner goals and something that we really say explicitly to them. We want to make the best use of your time. We want you to, if possible, have something to take home with you, and so let's develop scenarios to address that. We can do multiple brief scenarios rather than, at least previously, we felt really constrained that it had to be one mega case, the mega code analogy that one of our pediatricians mentioned. So we got more people on board. I just look around the room and I see fewer people disconnecting. I feel fewer people being frustrated or wondering what we're doing here. The energy tends to be higher, and we just feel like we're having more wins, more upbeat ending to the potential and promise of relationship-centered communication. So the outcomes seem to be good. Now, we have not done any formal analysis or comparison of surveys between the old way and the new way, the classic and then new development, but it seems to be going well. Now, one potential downside is that the group may miss the opportunity to see all 3 skill sets in sequence, and I think that can be a downside, although nothing says you can't sequence things in that way, looking at the learning issues. So you might be able to suggest, let's pick a scenario that has to do with the skill set 1, then let's move on to a skill set 2 type of scenario and skill set 3. As I already mentioned, our PERC trainers are really enjoying this and continue to use it. And I think there will be some opportunities for ongoing skill development, particularly in this kind of responding flexibly to the learning goals that are coming up and the opportunities that arise. That's why I mentioned jazz. So, melodies arise, and it's a windows of opportunity and that sort of thing. And I have found it personally very rewarding to do that. So that's the prepared comments that I have, and I really appreciate everybody hanging in there and listening to a monologue when we certainly want to encourage dialogue. So this is a good time for dialogue, comments, and questions. And I do appreciate everybody's attention and hanging in there.
Thank you, Peter. That was very informative. And so I'm going to turn it over to all the participants, as I imagine you've been generating some questions or thoughts that you may want to dialogue with the group about. And we really welcome your discussion here, as the intent is for you to be able to share thoughts and ideas about your practice with this.
This is Michael Bennick. I was wondering how you addressed the ebbing energy at the end of a day. Did you find that the energy was increased by this process?
Yes. That was one of our, reasons to pursue other options, because it did seem like the energy would get low, particularly if the case started to seem frustrating and everybody's scratching their heads. Not that being frustrated and scratching your head isn't a wonderful learning opportunity, but at the end of the day, sometimes it's just kind of stayed low. So I think by doing more than one case, first of all, helps. We would have many of the nominators now are actively engaged. And then if you bring 1 or 2 other people in on some of the scenarios, let's say they're giving feedback and have a suggestion where you can put them into the learner seat and they can begin to participate. So yeah, I think it feels just really connected with daily reality. And of course, we have some non-clinicians who work in administrative positions, or we have people from our diversity and inclusion office. And I think at least my hunch is that they have found this type of exercise much more engaging, because they can say, okay, I don't do this clinical work, but people come to my office daily reporting, some microaggression or adverse thing that they've experienced, and say, well, I like to practice that. And so we're not constrained by having to stick with the classic format.
Thank you, Peter.
Yeah, I also find that the rapid fire sometimes really gets people energized. And I don't think I'm just projecting, because I usually have a co-facilitator and say, yeah, it seems like it's moving along.
Thank you, Peter. We've had a question come up on the chat feature from Sandro Bellucci. And Sandro, I'm not exactly sure what organization you're from. So I'm wondering if you might put that in also, so I can let Peter know. Sandro's question is, have you developed a specific training curriculum for trainers to learn how to conduct the challenging case exercise?
Yeah, that's a really important consideration. And so our reality is that all of our 8 trainers went through the formal, traditional rooted training, which included the integrated exercise. They developed facilitation skills, and they were part of developing this particular approach. So they had ownership and buy-in. And as I mentioned, they felt like they were using most of the facilitation skills that they had already learned. That being said, I think that if this was to be part of, let's say, a new Train the Trainer initiative at an institution, or as we move forward and expand our base of trainers, I think we will train in this exercise. I'm looking forward to that. And I don't see it as being hugely difficult, because at least our trainers have felt like this makes more intuitive sense to them, that you're basically moving into more challenging cases, linking it to the basic skills and whatnot. And it just seems like it's intuitively sound and has face validity and that sort of thing. But it would require, I think, if you're moving forward, some consideration about that. And I think that would be one of the great things for this particular group, is to work together on that. To have a group of people sharing ideas about how to build this into trainers.
Thank you, Peter. That was from Sandro Bellucci, who's the executive director at North Shore University Hospital. And we've had another question come up that shifts gears and thinking a little bit, but Lori Devon from Yale has asked that in regards to your mention of a group of neurologists whom you were training, does Wake Forest tend to teach by service line? And what are your thoughts on that approach versus having a broader group of various backgrounds?
Yeah, so that was specifically that was 3 neurosurgeons in a group of 10 participants for that particular course. We had a lot of thought about whether to do it by service line or by discipline, professional identity and that sort of thing. And we ended up doing interprofessional, interdisciplinary workshops, and that's been really going well. Now, several service lines have said we really want all of our folks, or we set a target of 90% or 100% to attend a PERC workshop. And so we may have a pretty good handful of them in one particular workshop, but we're not doing it by service line. For what we're calling PERC 101. Now we have PERC 202, which is de-escalating challenging interactions and responding to difficult patient requests. Now that we're doing with smaller groups by service line. Okay, so we're meeting with allergy, immunology, or rheumatology, or pulmonology, and we're doing emergency medicine, etc. But most folks have found that the interdisciplinary, interprofessional makeup of the group is great. Most of the interactions have been really respectful, but we're going to bring that up as a topic for discussion going forward about how to deal with some of the challenges that could arise when you have a variety of different professionals. I'll just make a comment. The very first group that I did, we're going around and one person says, I'm so-and-so, I'm the chair of emergency medicine. And the next person said, oh, I'm so-and-so, and I'm a pediatric intern. And I'm like, oh no, how did this happen? And it turned out it worked fine.
Thank you. That's insightful. We have a lot of programs that have an interest in knowing what kind of the best practices in terms of aggregating people by specialty or creating mixed groups. And we've heard feedback similar to what you're sharing, which is there's benefits and disadvantages to it both ways. So thanks for sharing that. And I'd like to prompt the rest of you for...
But I would just say that if, and this just hasn't happened, but if a particular service line said, we would like to do some workshops for our folks, we would be delighted to do that. So we're flexible and not wed to one approach.
Thank you, Peter. What other questions or thoughts come to mind for the group? I can imagine there's 20-some people here on the line, and so I'm imagining you may have faced some hiccups or challenges with your final closure of the day through the integrated exercise. And so I'm interested in hearing what some of them might be. And in the meantime, as you percolate on that, percolate, Peter, no pun intended.
Oh, please.
A question from Kirsten Bechtel from Yale is wondering, is PERC mandated at Wake Forest and where everyone has to do it?
So the simplest answer is no, not mandated across the health system, which is getting really large and just about tripled 2 weeks ago. No, quadrupled, I think, 2 weeks ago. But our CMO, when first actually came to us and asked us to do a communication skills workshop of some sort, he was really down on trying to make it required for all the various experiences he'd had when the C-suite or the 10th floor mandates things to others. Of course, you know, it's not so simple as that. So currently what we're striving for is to set targets of high attendance through departments. And we have our CEO has been on our side, but we haven't exactly set punishments if someone doesn't do this. It's more, we try to entice people. First of all, it's a great experience. Our reviews have been fantastic. A number of the practices now include attendance with their, you know, as part of their quality metrics. And so if you attend, that helps out then with your compensation package. That's been a really big thing because we now have a number of community practices, and it's more challenging for them to attend, take a day out of their office than it is for folks in our academic center. I would be interested, you know, to know how many institutions are going to the required format, let's say like Cleveland Clinic, and how many are not. But I think it would be awkward to try and poll using this the system, and I'm not sure it's actually on the maybe the focus. I want to be sure that if there's issues that come up around the this exercise, that we get a chance to address those in the last 5 to 10 minutes. Do folks have other things that you would, does this interest you? Do you think it would be difficult, or maybe you're already doing it? I'd be interested to hear.
It looks like Sandro Bellucci has a question. So okay. Sandro, feel free to ask Peter.
Thank you, Vera. Can you hear me?
Yes.
Okay, so, you know, we are a very large health system, 23 hospitals. We started the RCC course about 2 years ago, and so far we have trained about 1,000 clinicians. In general, has not been mandated, and the attendance has been quite good.
Yeah.
We have one particular service line which decided to mandate the attendance of the course, and I became aware of that simply by spotting the body language of those participants at the beginning of the sessions. Mm-hmm. But clearly, they did not want to be there. They were sort of forced into it. However, I would say that in general, by the end of the day, they were very much engaged.
Yeah.
And truly appreciated, you know, the skills that they had learned, and they felt that it was a very valuable use of their time. So, and I also have yeah, go ahead.
That's wonderful to hear. What institution are you at?
I'm at North Shore University Hospital.
Okay, good.
Part of Northwell.
Yeah.
And the question I have is that you know, the concern that we have is how sustainable these skills are. We have started at the hospital what we call sustainment sessions, and it usually is an hour and a half at lunch, where we engage between 10 and 20 participants that have attended the course. And we basically review with them the skills and ask them, you know, what worked well and what did not work well. we were struggling with the idea of including integrated cases because it would be extremely difficult
Yeah.
to enact in that kind of scenarios. But I think the challenging case exercises are particularly suitable for that small audience for that hour and a half that we do the course.
Mm-hmm. I agree that it's a little easier to expand it or make it a smaller thing, and you do just a couple of cases, and they could be relatively focused rather than so extensive. Yeah, that's great. That's great. We've been doing some sustaining sessions, and we always want to add maybe a little new content as something new or some phrases that they could use in challenging interactions. But the core is always to return to the fundamental skills of listening and responding and that sort of thing. The core skills are the same.
We have just a few more minutes for questions, and it looks like there's been a little bit of discussion here on the chat feature. So Kirsten has noted that she has done both the integrated case and then the challenging clinical scenarios, and it seems to work depending on who the attendees are. For instance, if everyone is super engaged, she's tended to do the integrated case. If there's less engagement, to do several challenging case scenarios with specific skill sets seems to be fruitful. So he says, I guess it all depends.
Yeah, well, that flexibility and responsiveness is really very learner-centered and very group-centered. So I applaud that.
Thank you for sharing that, Kirsten. And then we have some other questions here that have come in since Sandra was talking. Dr. Ramdeo from Kettering has asked, what are some suggestions you might have in regards to follow-up after physicians have completed the course to make sure they're using the tools? And Tara Kringle asked a similar question for Sandro. So perhaps Peter and Sandro, you might dialogue about this. Do you have coaches that observe your providers post-workshop?
Mm-hmm. Well, I would first have a statement that I'm not sure that Wake Forest and PERC we are not as far along with this as we would like to be, and eager to learn from others who are doing more. A couple of things we've done. We've had a project with our hospital medicine group where after attending PERC, we'll go up to the floor and I'll observe. So we have about 4 of us who have done this, observe a clinician with 2 successive patients. So it's not like watching them, we just on time, but watch them with 2 successive patients and a little bit of a preamble, just, coaching, connecting with the clinician, watching them for a couple of cases, and then doing a little feedback and reflection about things. And that has been well received, and but we have not measured the effectiveness, let's say, in terms of HCAHPS. We've been, we send out information about every 2 to 3 months. We send out references and new resources that would be useful for PERC graduates. And then we survey them as to what skills they are using. And it's been really cool, I think, to see how many of them are using the skills by self-report. We actually think it is a prompt to continue using the skills as well as a measurement. And we've been very pleased that over 80% state that using the PERC skills, as we call them, has increased their joy in practice. So we're, of course, very interested in the clinician experience as well as our patients. So I'm really delighted to see that. And I think that's been a selling point with our highest levels of management. But I'm interested to hear more about what other folks are doing. I just would also mention we have PERC 202 as opposed to 101. 101 is the fundamental course. 202, the only ones that we've been doing so far are the challenging interactions and responding to difficult requests. But we have ready to go motivational interviewing, goals of care, and breaking bad news or delivering bad news. So we have we have a few that are ready to go.
Wonderful.
Thank you, Peter. And now it seems like there may be a couple other questions or comments, so please feel free to voice them.
This is Sandro Bellucci again. May I go?
Yes,
Sure.
go ahead.
Okay. So there was a question in the chat if we have coaches to observe the participants or the providers post-workshop. And this is an issue that we are struggling with right now. I think there is value in using coaches. The difference of opinion is if these coaches should be clinicians who are particularly good, that are trainers, or if we should have more of a professional non-clinician coach. Have you guys thought about this?
Well, there's a variety of programs going on. I know one at, well, no, I'm sure it's not at UNC or Duke, which uses, rather than a medical clinician, using somebody with more of a social work, communication background who's doing a lot of coaching. But I think it's, this is labor-intensive work, and it depends how RVU driven you are and how much time can be devoted to this. One thing that I've been invited now by 2 clinicians to come to their clinic and observe them because they have continued to have some struggles with their CGCAP scores and that sort of thing. And, that's a real honor to be invited to observe, and I think it's been productive. But as I said, I'm interested to hear, I think everybody on this call would like to know strategies for helping to reinforce, maintain, continue to encourage and support people in using these skills going through their careers.
Thank you, Peter. And this dialogue is really helpful to myself and Rachel and the rest of the team at Engage as we think about what topics will be of importance to you moving forward for future webinars. And we have definitely set our sights on helping support our client partners with coach development and coach strategy. And as Peter, I'm sure, will offer for you to reach out to him offline, I'll also offer the same thing, in that if you have questions until we do further learning around coaching and skill reinforcement, please don't hesitate to reach out to me also. This is Greta Rosler speaking, as I'm happy to talk through it with you, as that's much of the work that I'm involved in with the Academy. With that being said,
well, I just want to make a comment. Thank you. That's a great invitation and proposal for future conversations. I would just like to say in closing for myself, how delightful it is to have a group of professionals who are so interested in this dimension of our professional work and our personal lives to spend this time. So thank you for joining me, and I learned a lot just hearing the questions, and I'm challenged to continue learning.
Thank you, Peter, and thank you all. And if you'd like to hang on for just one moment, I'm pleased to turn it over to Rachel, who can tell you a little bit more about where you can access some of these resources we're discussing both now and in the future.
Thanks, Greta. This is Rachel Porch speaking, and to carry on this great collaboration that we've begun today, we are excited to announce that we are launching the ACH Train the Trainer online community to provide our partners and trainers, administrators, a place to connect and share ideas and resources and access the latest materials and just resources that we send out on behalf of the Academy. These will all be housed here. So this community, it's a private group, so only those who have been part of or currently part of a Train the Trainer program will have access. So the community features a discussion board where you're free to start a discussion forum by asking questions, sharing trials or triumphs, asking for feedback, sharing resources. The list could go on, and perhaps a good idea would be to start a discussion on behalf of today's webinar to kind of talk about reinforcement of this topic. The community also features a library, which we have already begun to build a repository of relevant resources to which you are welcome to add to. So this webinar series is going to be recorded and added to the community library for access at a later date. Now, this community is accessible to ACH members only. It is part of a membership benefit. So if you are unsure of your membership status, you can check with your program admin or feel free to contact us directly. And we are excited to announce that this first webinar recording will be accessible to all individuals, regardless of your membership status, as the first inaugural webinar. But future webinar recordings will only be accessible to those who are ACH members in this community. So you will receive an email from us here shortly after the conclusion of this webinar, and that email will include access to this recording as well as access to the online Train the Trainer community. And I also would like to mention that we will have an upcoming interactive webinar similar to this coming in July, and that topic will be on reinforcing skills using micro skill booster method. And that webinar will be facilitated by our colleagues from the Train the Trainer program at the University of California, San Francisco. So those are the upcoming things to look for in your email here shortly. And I would just like to say thank you to everybody who joined. Thank you to Greta for moderating, and thank you to Peter for such a great webinar today.
Thank you, everyone.
Thank you and goodbye.